Good evening, everyone, and welcome. We, the NAACP Worcester branch, are partnering tonight with AdMeTech Foundation, hosting this virtual forum to discuss the emerging advances in patient care and related racial and ethnic disparities. With the focus on prostate cancer and COVID-19, AdMeTech Foundation provides global leadership in transforming patient care and life-threatening diseases. This event addresses the critical importance of public education, awareness, and access to the high-quality health services for saving lives and eliminating health disparities. So we at the NAACP want to thank you for joining us tonight. And me personally, I would like to thank our executive committee, the Worcester branch NAACP. Like all NAACPs, our volunteer organization. No one gets paid for doing this very important work that we do here. So I'd like to thank Ed Robertson, first vice president, Nellie Medina, second vice president. I'd like to also thank Doreen Otten, our secretary and treasurer, our member at large, Rich McCool, our assistant secretary, Fran Graveson. I'd like to thank our chair for our education committee, Kristen Waters. I'd like to thank Barbara Mudd. I'd also like to thank Juji Diamondstone, our Environmental Climate and Justice Committee chair. The Worcester NAACP has been carrying some of the hot spots in the state of COVID-19 pandemic, overlapping with the prostate cancer health disparities. Tonight we have some star-studded panelists here. So without further ado, I'd like to introduce the first speaker. Our first speaker tonight, Senator Michael Moore, is someone most of you on the call know, but one thing that you may not know is that Senator Moore is also a member of the Worcester branch NAACP, and he's regularly involved and is always showing support. Senator Moore is a chairperson for the Senate Committee on Post-Audit and Oversight. So without further ado, I'd like to introduce Senator Michael Moore. Thank you.
Thank you, Fred, and thank you to the other committee members for all the work setting this up and the work they do throughout the year, advocating for these issues. It takes a lot of time out of their personal lives and commitment to do it, and a lot of time and commitment from yourself. And thank you to all the other speakers here tonight. And I just want to say good evening to everyone, and thank you for being here today and allowing me to say a few words before we get started. First off, I would like to thank the Worcester NAACP and the AdMeTech Foundation for hosting this event and for their continued efforts to raise awareness on this issue of prostate cancer in African American, Hispanic, and Latino men. Because men of color are 2.5 times more likely to die from prostate cancer, it is crucial that we have equal access to preventative care throughout the Commonwealth, something that the NAACP and the AdMeTech Foundation are both committed to ensuring. This issue has been further compounded throughout the pandemic as communities of color have been hit harder by COVID than others, which speaks to our need to create a more equitable healthcare system. And while the pandemic has challenged all of us, and in a variety of ways, those living with underlying conditions such as prostate cancer have dealt with a greater deal of anxiety than others. These feelings of anxiety have been heightened with the surge in cases that were brought forth by the Omicron variant. And while we are now seeing a decline in cases, it seems that we will have to continue to live with this virus in some form for the foreseeable future, which further exacerbates the need for proper access to healthcare, especially for African American, Hispanic, and Latino men who are at higher risk of prostate cancer. Because of how crucial it is that we address these issues and create a more equitable system, I am so grateful that we have here this wonderful panel tonight who will offer the latest information on the pandemic, prostate health, and prostate cancer treatment. I want to thank again the Worcester NAACP as well as the AdMeTech Foundation for organizing and hosting this event. I can't wait for this event to get started here tonight. And again, I want to thank AdMeTech Foundation for all the advocating they've done. I first became knowledgeable in this issue through their work in advocacy at the State House. Once a year, I would have a visitor come see me, and she's going to be speaking in a few minutes to keep me up to date on all the important data that we need to know in trying to address these issues. So again, thank you, Fred, and thank you to the other speakers, and I look forward to hearing all the information given out tonight.
Thank you very much, Senator. I appreciate that. So I see my district counselor just joined us. Thank you very much, Councilor Rivera. I appreciate you showing up and giving some support.
No, thank you. This is a really important topic. Thank you so much for all your work on this.
Our next speaker is a person who has been a strong advocate for the city of Worcester and the State House, ensuring that Worcester gets its fair share of state support. So without further ado, I would like to introduce Senator Harriet Chandler, Senate President Emerita.
Thank you so much, Fred. I'm not sure where to begin here, except for many of you, you've heard what I have to say on this subject. About 25 years ago, my husband, I had breast cancer, and my husband, for some reason, refused, as many men do, to take a test. He refused to even talk about it, think about it. And the more he refused, the more adamant I became, because I know what my breast cancer had meant to me. And I became very insistent on the subject. And by and large, he finally gave in, and he finally went and had a test. And when I asked what his PSI was, he said, I don't know. He didn't have that. He had just a digital test, and that wasn't sufficient. Men don't like to have these tests, and I don't blame them. They're very intimate. They're very embarrassing, and it's not the most comfortable thing in the world. But I'll tell you something that's less comfortable, and that's getting prostate cancer itself. Because prostate cancer, which my husband ultimately found he had when he got his test, is much, much worse, and it can be with you for a very long time. We know the figures. You've heard from Senator Moore, and you'll hear from others today who can tell you just what the figures are, especially for people of color, who are particularly A, uncomfortable getting the test, and B, who it happens to be very prevalent. And the less you test, the more the chances are you're going to have something like this. So I can only urge you, I can't urge you strongly enough. Don't be like my husband to wait too long, because it may be life and death for you. It's as simple as that. I think that that's all I need to say. I think you understand exactly what it is. Don't wait until your wife begs you and pleads with you and says, it's your life that we're talking about. Take your life in your own hands and find out. Get regular testing for prostate cancer. I want to thank, as the my Senate colleague just did, AdMeTech, for making it a focus of theirs to test, to educate, to inform. It is so, so important. So it may be your life we're talking about. Get tested. Thank you.
Thank you, Senator. Our next presenter, our next speaker is someone who most of you know on the call. I want to thank Dr. Castile. She has made certain that equity has been part of Worcester's response to COVID-19 pandemic throughout the last 2 years. She's been working tirelessly on the front line. I personally have respect for her, and I know a lot of folks in the community have a lot of confidence and respect in her, and we really appreciate the work that she's been doing. In fact, on the front lines, I was fortunate enough 3 weeks ago to get my booster shot, and she was on the front lines giving the shots out. So I want to thank her personally again for doing that. So without further ado, I'd like to introduce the Health and Human Services Commissioner, Dr. Castillo.
I wanted to say thank you very much, Fred. I wanted to know if he did okay with his vaccine. So you're all right?
Yes, I did. Yes, I did.
Okay.
No side effects.
All right. I'm going to just give you an update of where we are with COVID-19. And we know that, COVID-19 disproportionately affects communities of color. And people say, well, this is new. This is something that we've seen now during COVID. And the reality is that we know that the inequities that do exist throughout healthcare and that I've seen throughout my entire life, even as a physician, knowing that these issues have gone on for quite some time. And hopefully this is a time that we pay more attention to that and figure out ways to reach our communities and provide that equitable care. So I want to first tell you, most of you know where the Omicron took us, and you can sort of see where, what we were doing in the summer. And this is actually sewage testing. And so they take your stool and they from the sewage, and they were able to see how much Omicron is in your in the sewer water. So this number here is our newest number that we have. We have 2,710,279 copies of Omicron in our sewage. A week ago, it was 4 million. The week before that, it was 10 million. So you could see what Omicron did. And then we saw the peak, and then here we are coming down. This is what we've seen throughout other countries. That as quickly as Omicron rises, it will quickly decrease. And so we're looking forward to that decrease, but always to bear in mind that there are other Omicrons that are in the area where hopefully we'd like to be out of the woods, but time will tell where exactly we are. And this is actually the peaks that we've had in the beginning of March of 2020. Our first peak with Alpha, we went to Delta, and here we are with Omicron, which was the highest numbers we have ever seen. And this also tells you where we were with communities of color, and I'll point more to that. But the orange is the Latino community. And the Black community is this bluish kind of greenish color here. The white is the blue. And you will see those, how it affected communities of color. But just to note that here's Omicron compared to our first two waves that we've had. So when we look at vaccinations, we think about, that 49% of our community is white, yet 42% of them of that community was positive or got COVID. Latino community is 25% of our community, yet this is a disproportionate piece. 36% were affected by COVID. 14% of our Black community, 16% of that made 16% of the 14 was affected by COVID. And so you can see the biggest disparities that are here. And so Latinos and Black communities are disproportionately impacted by COVID in comparison to all the other groups that are here. And it's the same with vaccine distribution. Again, 51% of the vaccines went to the white community, 24 went to the Latino community, and 14% went to the Black community. So I'm gonna go over this. There's a lot of different ways that we sort of see the data, whether it's 2020 census, whether 2019 census. So there's different ways of how we do this, and I'll go over this a little bit more. I wanted just to show you what we call a public health emergency, and what in particular. What communities are the communities that are at risk for this public health emergency. But it can happen not only with whether it's a health emergency, or we talk about climate change and who is it going to affect and who's going to have the ability to survive and thrive. When we look at Worcester, we look at, in particular, who's impacted by COVID. And we see a particular area, these colors that are here in this particular area are the ones who've been impacted the most with COVID. If you look at superimposed where the Latinos live in the community, it superimposes right in here. And if you look at the Black community, it superimposes right in here. These were our highest numbers of COVID. And then when we look at socioeconomic, so all of these superimpose on one another and fall into the same graph that is here. I'm talking about social vulnerability and who is going to have, who are the ones we need to pay the most attention when we have, whether it's climate change, whether it's any type of emergency, and in this particular case, the public health emergency of COVID. So when we look at socioeconomic, we look at who's below the poverty level, who's unemployed, who has no high school diploma, and you'll see the same graph that we go through here in that's superimposed in here in the same areas. We look at household composition, anybody who's 65 years or older, 17 or younger, or older than 5 with a disability in a single parent household. Again, we go back to the same outline that we've been seeing. Look at minority status, somebody who, speaks English, as we say, less than well, same area that we're talking about right here. Same happens with housing type and transportation. People who live in multiple structures, mobile homes, crowding, that they don't have a car, or they live in group quarters. So they all superimpose on one another. And this is the what we call the social vulnerability index for our community. These are the people that we need to really pay the most attention to. And when we talk about the top 1% of that has the most social vulnerability, we're looking at Bell Hill and Great Brick Valley, which were the same who got the most COVID and also the least vaccinations. And this is just a graph talking about the same thing. But when we look at the 2020 census, which we know it's 200,516, something like that is our new census. When we look at that census, we see that Worcester received 70% of the first dose, and that 60% were fully vaccinated. And this is the last data that we got January 21st of this year. And then if we look at eligible population, and then they also do it, the state does it with 2019 data. So that's different census. Eligible population means anybody from 5 and above, those who have the ability to get vaccinated. So we see that Worcester received 80.3, received their first dose, and 68.1 were fully vaccinated. Most of you know, everybody from below 5 have still not been vaccinated, and that's why, in a sense, those numbers are also higher. But again, the distribution, the lighter colors are the ones who have I think these is vaccination rates. So these are more of the darker are the more vaccination rates. But still, the areas that have not are still here. But these are the ones who got COVID. And again, overlies in the same areas as we were looking at before. When we look at the 2019 Mass DPH and compare Worcester to the state, again, eligible people, that means everybody from 5 and above who have been fully vaccinated. We look at our numbers and we see the disparities that do exist. We see that, American Indian and Alaskan, 38.3% of Worcester, and that's a small population, but still 38.3% have been fully vaccinated compared to Massachusetts at 43. But when we look at the Latino community, 54%, 54.9 have been fully vaccinated in Worcester compared to 65.3 at the state level. And Latino community is 53.3 compared to 65 at the state level. And here's the white community at 70.5 and state is 74.4. And the Asian community is still doing well with vaccinations at 70.1 and compared to the state at 78.4. Truly, the disparity exists here and exists here. And that's a lot of what we've tried to do is try to, improve these numbers right here. We also see the disparity in the sense, and we don't know by race or ethnicity here, but looking just at age, and we're again looking at MassDPH 2019 census data for eligible population who are fully vaccinated. You can see where we lag behind. It's in this age group here. So if we look at anything from above 30 on, our numbers are great, and at some point we're even better than are we better? I thought we were better. Yeah, we're better at 65 to 74. We're higher here than the state. 50 to 64, we're a little bit higher than the state. So in those areas, we're doing pretty good. Now you look at the 5 to 12-year-old, and you can see that 17.8 have been fully vaccinated compared to 36.9. So you can see the disparities here, but also the lack of vaccination, I should say, that happens here. Again, 12 to 15 is 55% have been vaccinated. 16 to 19 drops to 48.8, and 20 to 29 is 54. So here is really where where we have to concentrate to get most of our youth vaccinated, and that's what we've been trying to do. When we look at, again, MassDPH data, total population, we know that 75% of Worcester has received at least one dose of the vaccine, and 64% are fully vaccinated. When we compare ourselves to others, and in particular, when we look at the booster shot, and we're right here, 23% of our population, that's our entire population. So it's not just who's been vaccinated, it's our entire population have gotten 23% of the boost. And then you look at where we are with who's been fully vaccinated at 64%. So if you look at these numbers, this is Worcester. So this is Worcester here, boosted compared to Springfield. We're about, we're a little bit better. Here we are in New Bedford, a little bit better. Lowell, a little bit, we're the same. So those numbers are about the same. When we start looking at, we're here looking at Chelsea and Boston, you could see the difference in the numbers here. And again, booster shots were about the same across, except right here that Boston is a little higher than us. We still have a ways to go. And then when we look at the disparities across our community, Worcester is this brown one right here. And this is, so when we compare Worcester with the white population, here's where we are with the white population. In particular, let me look at, you can see the different places. Boston is the dark blue, Chelsea is the orange, and this is, we are this color here. So you can see, in particular, in the Latino community, where we are in Worcester, which is right here. So we're about, we're right here with the rest, Lawrence, Lowell, Fitchburg, we're right about here. But look at the Latino community here, which is Chelsea, how much it's done. When we look at the Black community, we're right here, again, falling, not, pretty close, but not, these are not great numbers. But we look at the Black community here, which is Lawrence, much better. So sort of seeing the difference, and then you look at Boston, which is really, in the Latino community, you can see the orange here compared to, this is for the Asian community. You can see what they've been doing. When we look at the boosters again, by race and ethnicity, you can see when we look at the Black community, it's the orange. So this is Worcester. So only 12% of the Black community have gotten boosted. And when you look at the Latino community, is 9%. And you can move down and sort of see that New Bedford is, a little bit better here in the Black community. But pretty much our booster numbers in both communities of color are much lower, except when we get to Chelsea and Boston. When we look at, so one of the things that happened in Worcester is that the state picked 20 cities that they were going to give the equity vaccine, that they felt that, we would have those issues with equity and wanted to make sure of where we were. And if you look at here, and this is eligible, these are age eligible population for the vaccine. And again, it's for those who have been vaccinated. And so you see that this is the communities that did not get the equity vaccine. This is Massachusetts statewide. And here's where Worcester is. So we're at 43% of those eligible got the vaccine. So we're a little bit better than others. And I don't want to say we're better better than one or the other, but we still have a long ways to go to where we want to be. But truly, it has been an effort to get to where we want it to be. And then when we look at those who have been fully vaccinated, fully vaccinated individuals, we look at the booster rates, and here's where it is right now. And you can see that we're pretty close to basically to the United States. Overall, Massachusetts is doing much better. And this is some of the things that we've done in the city. Is truly we've been going mobile. We've gone to lots of different places mobile. This is part of our vaccination team. Looking at what we've done overall, we have administered just from our HHS team 32,258 doses have been administered. We've administered to 15,000, almost 16,000 people. How many people we've seen in the Worcester Public Schools? These aren't great numbers. We need to continue and push and try to figure out, but this is what we've done so far. Looking at those where we've gone and done community clinics, we've gone to places of worship, we've gone to places where people work, we've gone to different businesses all together to get these numbers. And we've started at the Worcester Public Library, where we have some solid dates that we go to, and those are our numbers. And we've can't tell you how many town halls that we've done, over 30 different places. We've had 464 mobile clinics. We've had incredible youth vaccination efforts where we've partnered with all the different agencies to really get them aware about getting vaccinated. We've had lotteries. We've had all kinds of different ways to get people to be a part of the process. This is our post-vax youth campaigns. You can look at the video when you get a chance, but truly putting this in we've made posters that any one of you can have to put them out there. They're in, you can find them in billboards, they'll be in buses, and certainly we'd love to have this really produced elsewhere. These are kids from the community that people can relate to, so that youth can continue to get vaccinated.
Thank you very much.
Mm-hmm.
So next up, I'd like to, I first met Dr. A in the midst of the pandemic. He gave a fantastic presentation to Black Families Together, as I said, in the midst of the pandemic. And when I heard him speak, I said, wow, I'd love to have this doctor come and give a presentation to the NAACP. And, fortunately, we planned this event, and we planned to talk about prostate cancer and COVID-19. So it presented an opportunity for me to ask for him to come and speak about this. And thank you very much for accepting the invitation. So without further ado, I'd like to introduce Dr. George Abraham, who's a professor at UMass Chan Medical School, and he's also the chief of medicine at St. Vincent's Hospital. Thank you.
Thank you, Fred, for that kind introduction. Thank you. Always a lovely opportunity to connect with the community, especially people of color with whom I have a dear relationship with, just because it's so important that we talk to, educate, and any opportunity to speak to groups such as yours are just a delight and a pleasure. And so I'm indeed honored to be asked to speak. I will keep my comments pretty brief so as to allow for more interaction at the end. And just to say that vaccines and masks are probably the two big things that are most relevant to us. And so we continue to face challenges with vaccine adoption, as Dr. Castile eloquently pointed to, areas, especially with our people of color and communities of color who still struggle for varying reasons, and the vaccine hesitancy rates continue to be fairly high. So we've known well that with 2 doses of vaccine, it's not enough. Usually in about 6 months, the vaccine rates drop or the efficacy drops, which means more and more people are likely to get sick after 6 months of having had 2 doses of vaccine. So there's now robust science to support that a third dose of vaccine, which is called the booster for some people and a third dose for others, and the CDC differentiates the nomenclature because for people who are immune suppressed, in other words, unable to fight infection because they've either had a transplant or are on medications which specifically suppress their immune response, they need not 2 but 3 doses. And so that third dose, the CDC terms as a third dose for them. And for people with normal immunity who are neither transplant recipients nor are on medications which suppress immunity, it's called a booster. So conceptually, while it's the same dose of vaccine, it's given different names in different settings so as to further or better elaborate the rationale for why we use 3 doses. In the same vein, you heard the term that Dr. Castile used, which was fully vaccinated. And so one might question, what does fully vaccinated mean? And so the CDC has elected to keep the term fully vaccinated to describe people who've had 2 doses of vaccine. And so has introduced a new term called being up to date. So people who've had the third dose, the booster or the third dose of vaccine, are now considered to be up to date. So they are up to date with all the required doses of vaccine that they are eligible for. So you're either up to date or not up to date in terms of your vaccination. And so fully vaccinated has really moved, and the target has moved to being up to date. So you might ask the question, how did the name Omicron come about? And so the Greek alphabet, so we'd exhausted all the way from alpha to mu in the number of variants that existed. The next name was new, but because new could be confused with NEW, new. And since all these variants are new, as is the virus is relatively new, so the name new was dropped. And so then came the question of what next, and the next letter in the alphabet was Xi or Xi, and which was very close to the Chinese name Xi, and so that we felt, or scientists felt, could be considered pejorative to the Asian community, and so therefore that was dropped, and that's how we ended up with the letter O, or Omicron, as the name of the current variant. And so we had Delta circulating for the large part till Omicron took over. And so now we recognize 99.5% of disease in the United States is Omicron. And rarely we've seen combinations of Delta and Omicron called Deltacron. So where you have dual infection with both variants. And so there are other variants on the horizon. But at this point in time, this is the dominant variant worldwide. So to give you perspective, Delta was a variant which had severe disease associated with it. So severity of infection is extremely high. But Omicron became notorious because of the number of mutations, the way the virus changed its outer surface, so that if you looked at vaccine as a lock and a key, where the key fits into the lock because the grooves are in a particular conformation that match perfectly, it changed the grooves inside this lock so that the key no longer fit into the lock. And so that's why the vaccine became less effective in these circumstances, especially vaccine that targeted the spike protein because of the number of conformational changes. And so this is from the New York Times, which did 3D electron microscopy of the spike portion of the protein, showing in yellow all the different conformational changes to suggest why so many mutations made Omicron difficult. So while Omicron is highly infectious, it's an extremely mild virus, and so therefore people have had mild disease. Reflective of that is data from all over the world, both in children, so children under 5 who are the only group as yet who are not eligible for vaccine. Hopefully that'll change in the next month or so. But till then, even then, if you look at Omicron, the rates of hospitalization, ventilation, ICU admissions, ED visits, so severity of illness was much lower in Omicron compared to Delta. And these numbers bear out about the same for adults as well. What's depressing about this is the fact that people who've had prior disease, whether Delta or previous variants, did not have much immunity to Omicron. And vice versa, having had Omicron, it's not expected that they will have long-lasting immunity to other variants which come down the road. So what's the moral of the story? Immunity due to natural disease, so which means immunity from infection, is not robust, nor is it long-lived, and does not equate to immunity from vaccination. So that's the rationale for whether you've had disease or not. Everyone should get vaccinated as soon as they are free of disease, because the vaccine is the only one which induces a long-lasting immunity because of what we call the memory response of our immune system. So where it remembers the pattern of the virus and so is able to mount a challenge when re-challenged by a virus or similarly looking viruses. So clearly, immunity from disease, so people who think I've already had COVID, so I'm protected, why bother taking precautions, or why should I get vaccine? There is robust science to suggest that that immunity is not going to keep us going forever, and we're going to be prone to repeat infections. Testing has been a challenge and has been a conversation and a subject of both national debate as well as local debate, both state and locally. During the peaks and surges of virus, where lots of people have been looking for tests, there aren't enough tests going around. And so the debate has been, should you get a PCR test or should you get a rapid antigen test? And so what's different between the two? And can we rely on one versus the other? So clearly what we understand from this disease is that symptoms start before virus starts climbing in the person's body. So what we are seeing, first of all, with the Omicron variant is that people started getting symptoms usually a day or two later that their test turns positive. So people tested this time and their test comes negative. They say, okay, my test was negative, so I'm okay. I don't have COVID, but that's not true. When you repeat it about 48 hours later, you find we capture the viral. By the time virus is multiplied enough that that same test, which was previously negative, now becomes positive. So an important piece is that as symptoms are starting, it might be prudent to either test then, and if it's negative, to retest in 48 hours or so. And that's a rapid antigen test is just as good as a PCR in this setting, only because we have so much of virus circulating in the system. We have so many people getting positive every day. So the prevalence, the amount of disease that's present in our community is still so high that even a test with lower sensitivity, lower ability to detect, such as a rapid antigen test, a positive is probably a true positive and not a false positive, and should be considered positive disease. You don't need another PCR test over and above it. If you have access to PCR testing, so be it. And that's definitely much more sensitive and more likely to be true positive, but the absence of that shouldn't. So the challenge has been, as more of these home tests become available and made free or otherwise available, people are testing at home. So the trade-off is that while that is good and people are able to detect whether they do have disease or not, the trade-off is they are not reported, and so therefore we may be underreporting, we may be underrepresenting the amount of disease burden in the community because we're not capturing every positive test. And so we are relying on people being responsible citizens and isolating themselves if they test positive, because there is no other way to police the system. This is just to illustrate the point that I alluded to earlier when you compare the rapid tests with, or the home tests as we call it, with a PCR test, which we consider gold standard. So when we do PCR testing, the way the test works is basically the test goes around. So think of it this way, that you're putting a fishing line into the water and trying to hook a fish. So every time you dip a line into the water, that's called a cycle, one cycle. So the number of cycles it takes before you snag a fish is called a cycle threshold, called the CT. So generally 30 cycles, so 30 times that it takes is considered the threshold for considering positivity. So as you can imagine, the more number of cycles it takes to pick up virus, the lesser the amount of virus. So that means when there's little virus, it takes more number of attempts to find it. When there's a lot of virus, it takes a lesser number of attempts, so the cycle threshold comes down. So now in blue, you see the rapid antigen test, and in yellow is the PCR test. And so when the rapid antigen test is positive, even at a low cycle threshold, which means that when there is abundant virus, the test remains positive and it overlaps the PCR. So in other words, meaning that the rapid antigen test is just as good as a PCR when there is a high burden of virus, as is now prevalent now. So when we go through a period when we don't have much virus in the community, this test may miss cases because at higher cycle thresholds, it is not able to capture. And so we might have a false negative. So the moral of the story is our home testing is just as good at this point in time. A brief word about treatment options, and then I'll wrap up. If you have no illness, prevention, there is only one monoclonal antibody, which is currently not licensed in the United States, and so not available for pre-exposure prophylaxis, which is what's called PrEP. So when you have no illness, do nothing at this point in time other than our regular masking, etc. Post-exposure prophylaxis, in other words, somebody who's been exposed but hasn't developed active disease. There were two different monoclonal antibodies available. They worked well against Delta. They don't work against Omicron because they both target the spike protein, which has so many mutations like I showed you. And so therefore they are not useful. And so the CDC has recommended not using either of these. So they're not currently commercially available for that reason. So then comes the question of treatment. So mild to moderate treatment, they can be managed outpatient. We again have two different options. If it's Delta, works well. For our current Omicron, this will not work. There's only one monoclonal antibody called sotrovimab, which is currently available in limited supply. So the state rations it out to every institution in different parts of the state. And it's administered as a half-an-hour intravenous infusion. The person is monitored for an hour after you walk away. And essentially, most of the time, about 90% plus of the time, they actually do extremely well and never end up needing to be hospitalized. Now, 90% is not 100%, so there are rare exceptions when people have more serious disease or have more serious underlying illness, which might lead them to be hospitalized in spite of those efforts. There are two oral medications which have been approved by the FDA for emergency use. One of the two, molnupiravir, both of them are tablets. They're not recommended. So molnupiravir is not recommended in pregnancy. Unfortunately, it's not as efficient, about a 30%, 35% efficiency, which is not too great. It has some teratogenic potential, which is why it can be used in pregnancy. It's 5 tablets twice a day for 5 days, and that basically clears up virus, again, mild to moderate illness. The Paxlovid or the Pfizer is a combination tablet, which has two different medications in it. It has over 90% efficiency, so extremely efficient. But it has a set of challenges because one of the two medications, which is used to stabilize this other component in it, has a lot of drug-drug interaction. So there needs to be some careful checking and monitoring before it becomes available. Both these drugs are in limited supply right now, manufacturing just ramping up. And so there is very limited supply of both available. And so they are sort of rationed out to people who most need it or are in dire circumstances. And once they are in hospital, remdesivir, which is the drug of choice, so this can be used in the mild to moderate stage outpatient. It's given once a day for 3 days. In hospital, it's given once a day for 5 days. That's the primary antiviral, which is given for about the first 5 days. And given after the first week, it is of no use because the viral phase is over. Then is the inflammatory phase, where we basically use steroids or other medications to control the inflammation. Similarly, if the person ends up in the ICU and unfortunately goes on a ventilator, they actually do worse with remdesivir. So we stop it at that point in time. So that's what we have for treatment options. So this is nirmatrelvir, is the Paxlovid, the Pfizer medication that I alluded to earlier. It's probably the strongest or most potent. So about 18 people, the number needed to treat is the number of people you need to treat before you get success with one person. And so about 18 people you need to treat to be able to get success in one, but consider the biggest challenge is the drug-drug interactions. The sotrovimab is the only monoclonal antibody available as an IV infusion. 85%, so slightly less, about 17 people needed to treat it, but an IV infusion, not an oral medication, but very well tolerated and works well. Remdesivir, we talked about slightly lower percentages. You need about 22 people to get success in one. And again, that's used both outpatient and inpatient, but it's a multiple day infusion, not one day. There are some risks with kidney toxicity, etc., which needs to be monitored. And the last in the series is the molnupiravir, the Merck drug, which we said, as you said, we talked about the efficacy being only about a third of cases. So 31 people that you need to treat before you get success in one, again, not recommended in pregnancy. And this is just to give you a flavor of saying that we need to talk about significant amounts of drug-drug interactions with the Pfizer drug. The American Conference on Governmental and Industrial Hygiene did a nice study to show the relative value of masking and what the value of various masks are. So clearly no masks have the least protection. It barely takes 15 minutes before one will acquire COVID if the person who's wearing a mask and has infection, the person who doesn't have infection are together within 6 feet distance of each other. With Omicron, the CDC came out to state that even cloth masks were not as protective, and they pushed to say at least using the surgical mask, which is the loop mask that we talk about, because it has an inner white surface, which is absorbent of water vapor from the person wearing it. So that's the one which is worn facing inwards. The colored surface is always outwards, and it's impervious to splashes, and the reason why. So if that is worn, it needs to be a tighter fit. So it could be looping the ends so that it pulls closer to the face, so that it's a tighter fit helps. So definitely a surgical mask is better. But the government is planning to ship out, the federal government is planning to ship out what are called non-procedural N95 masks. So the white N95 masks, which don't have the outer colored, the green color coating on the surface, which is the splash resistant, but an N95 with an N95, if everyone were to wear it, you get over 25 hours before you acquire infection. So in other words, the best bet is for people to wear an N95, if not at least to wear a surgical mask. And so with the N95s have been the KN95 or the KN94, and the N95s are all what are called NIOSH, so the National Institute of Occupational Safety and Hygiene have approved it, and it's the 95 designation is 95% of filtration of the air, including viral particles, so which is why that's considered the best fit. The advantage of the non-procedural or the non-colored N95, the white N95s are, you don't need to fit test it, so it doesn't have to be a particular size to conform to your face, but it fits pretty well and is very protective. I'll stop there and we'll entertain questions later during our question and answer session.
Thank you very much, Dr. A. AdMeTech Foundation, as I said earlier, provides global leadership in transforming patient care and life-threatening diseases. I would like to talk about Dr. Fianna Stern. When I first met her, she gave a prostate cancer presentation for NAACP, that's our New England Area Conference, and she did a fantastic job doing that. So we had a conversation a few months back, and she offered to do this presentation with me and with the other doctors on the call. So I said, fantastic, and thank you very much. And it will be an honor for the NAACP to educate the public on these very important matters regarding health. So without further ado, I'd like to introduce the founder and president of AdMeTech Foundation, Fianna Stern.
Thank you so much, President Taylor. Thank you for the opportunity to be here. I want to thank everyone in Worcester NAACP. I also would be amiss if I did not thank Senator Chandler and Senator Moore. Without their support, we would not have had the kind of events we're having today. So thank you so much. I also want to thank St. Vincent Hospital and City of Worcester. At around February, when I was looking for a shot for a vaccine, the only appointment I could get was in Worcester. So I got both of my shots in Worcester, administered by St. Vincent Hospital. Thank you so much. This is your contribution to me and my family. Thank you. Actually, what we did, because we've had so many events and we've had so many problems with internet interference, we pre-recorded a brief educational presentation that will talk a little bit about COVID, and will transition the content of this event from COVID to prostate cancer. Before video will be demonstrated, I would like to acknowledge two members of my staff who are here with us today on Monday evening: Thomas Satam, and Ali Adam, who have been instrumental in making this event happen. Ali, if you can please demonstrate my video. I would like to express my gratitude to Worcester NAACP, particularly President Fred Taylor, for the opportunity to address prostate cancer awareness in the times of the COVID pandemic. This event is a part of the AdMeTech Foundation's ongoing program in prostate cancer awareness and education in Massachusetts, with primary focus on African American, Hispanic, and Latino men. Our program was initiated since 2014 with strong support from the Worcester delegation to the state legislature, led by Senators Harriet Chandler and Michael Moore, who are taking part in this event. I would like to thank our outstanding speakers who are affiliated with the University of Massachusetts, Dr. Matilda Castile and Dr. George Abraham and Dr. Mitchell Sokolov. Both COVID-19 and prostate cancer have emerged as leading health disparities in Black and Hispanic communities. In April 2020, early in the pandemic, we have recognized that the areas of prostate health disparities directly overlap with the pandemic hotspots. Since May 2020, we have expanded our program to include education about both prostate cancer and COVID-19, as reflected in this event. Prevention and early detection are critical for saving lives and eliminating disparities in both prostate cancer and COVID-19. The future of this pandemic depends on us. We can drive down infections drastically by wearing quality masks, particularly indoors or in crowded outdoor settings, in combination with reducing social contacts. If we develop flu-like symptoms, we can ensure early testing and self-isolation. It is important to detect COVID early when treatment can prevent severe disease. We can end this pandemic by complying with vaccinations. Our masks and vaccinations are the best way to protect not only ourselves, but also our families and our communities, including our young children who cannot be vaccinated. More than 8.5 million American kids were diagnosed with COVID, reaching record numbers in new cases and hospitalizations this month. Renee Graham of Boston Globe recently wrote about the unvaccinated and the orphans they leave behind. More than 100,000 American children lost their caregivers, and Black children are impacted disproportionately. This article raised a critical issue. Do we want our fears of the COVID vaccine define the future of our children? In July, U.S. Surgeon General Dr. Vivek Murthy shared publicly that he lost 10 relatives to COVID-19. He pointed out masks help us reduce spread of infection, while vaccinations remain the key to ending this pandemic. While we are dealing with COVID, prostate cancer cannot wait. And yet, many men avoid visits to their doctors out of understandable fear of contracting coronavirus. Unfortunately, delays in prostate cancer care can cause reduced quality of life and even loss of life. Clinical facilities created a safe environment for patient care, including virtual visits and telehealth. Ongoing care is particularly important for Black, including Hispanic men, who are 2.5 times more likely to die compared to white men. However, early detection saves lives and eliminates health disparities. With early detection of prostate cancer, every man is alive in 5 years. In sharp contrast with late diagnosis, when cancer is spread to other organs, only 28% of men remain alive at the same time. In prostate cancer, screening with blood test, called PSA, is the best tool we have for prevention and early detection, critical for saving lives and reducing health disparities. During pandemic, it is more important than ever to take charge of your prostate health. It is important to know your risk factors, such as African heritage, family history of prostate cancer, particularly brother or father, and increasing age, 50 and older. You can ensure early detection. During annual visit, ask your doctor about PSA blood test and digital rectal exam. You need to talk to your doctor starting at the age of 40 if you have risk factors, or at the age of 45 if you do not have risk factors. Before screening, it is important to avoid exercise or sex, which may impact your testing results for 1 week. After screening, you need to ask your doctor if your test is normal or if you need to see a prostate cancer expert. In September last year, AdMeTech Foundation held a virtual annual global summit on precision diagnosis and treatment of prostate cancer. Our annual summit brings together the key international medical experts to review the most recent advances in patient care. Screening of prostate cancer with PSA blood test reduced death by more than 50% and has been more successful in that regard than many other established cancer screening programs. My talk will focus on the advances in precision diagnostics, which have been transforming patient care over the last 5 years. In men before diagnosis of prostate cancer, we have seen rapid advances in accurate non-invasive testing of blood, saliva, and urine for molecular markers and genetic predisposition to aggressive prostate cancer. We are proud to have led pioneering research and large-scale implementation of non-invasive imaging, such as prostate MRI, which created a new standard in early detection of prostate cancer. These non-invasive diagnostics help us identify men who need to undergo invasive biopsies and eliminate unnecessary procedures. If you're recommended biopsy, ask your doctor what non-invasive diagnostic testing is available to make sure invasive biopsy is actually needed. Accurate imaging such as MRI has become a game changer in guiding prostate biopsies. In this slide, MRI shows prostate cancer lesions and guides biopsy needles with precision. Our summit highlighted the importance of MRI in Black men who are likely to have lesions in the front part of the prostate that are difficult to find by physical exam or standard blind biopsies performed without accurate imaging. In men with prostate cancer, there are 2 pillars of the current diagnostics, MRI and genetics. While MRI shows cancer location and local spread, what we call stage, genetic analysis of cancer tissue reveals underlying biology and probability of progression. With this precision diagnostics, we can now accurately determine which individual man has an aggressive, life-threatening form of prostate cancer and needs immediate treatment, and which individual man has a harmless prostate cancer, which is not likely to progress and cause problems and needs only a careful observation. If you recently learned you have prostate cancer, ask your doctor what accurate diagnostics are available to make a fully informed decision what is right for you, a careful observation or more invasive treatment. Recent large studies in veteran administration and military health systems show that with equal access to prostate cancer care, there were equal patient outcomes, including equal probability of death in Black and white men. Based on this and similar evidence, our summit concluded that access to high-quality care is the key factor in eliminating health disparities. It's particularly relevant to Massachusetts with its universal access to medical insurance. To achieve prostate cancer equity in our state, we recently expanded our education to include a program for improving access of high-risk men, particularly African American and Hispanic individuals, to high-quality clinical care. This program was created in partnership with leading state experts, including Dr. Sokolov and his outstanding clinical team here in Worcester. We have been working with men to match their individual needs with doctors who have the most advanced screening, diagnostic, and therapeutic resources available today. Our clinical care equity program is open to all high-risk men who are interested in consulting a leading expert about any aspect of their prostate health. This consultation may include an initial evaluation or a second opinion, virtual or in-person visit. You will benefit from this program if you are not sure prostate cancer screening is right for you and seeking more information. If you had screening already and have questions about your results. If you're considering an invasive biopsy and would like to learn more about non-invasive options. If you have a family history of prostate cancer and have questions about genetic testing and counseling. If you were diagnosed with prostate cancer and would like to learn more about treatment options. If you experience complications after biopsy or treatment. If after treatment, you have questions about the next steps, including prevention or early diagnosis of cancer recurrence or progression. Summer Mills, a member of the AdMeTech Foundation staff, serves as a statewide clinical coordinator for our prostate cancer equity program. If you have any questions, please contact her by phone 617-523-3535 or by email equityprojectcoordinator@admetechfoundation.org. We also provided information about this program to President Taylor and asked him to share it with members of the Worcester branch. In summary, prevention and early detection and related public awareness and education save lives and reduce health disparities in both COVID-19 and prostate cancer. Masks and vaccinations prevent COVID infections, hospitalizations, and death. Advances in screening and diagnosis created a precision, individualized approach to prostate cancer care. Thank you for your attention.
Thank you. I'd like to recognize a couple of Black Families Together members that are on the call tonight. I'd like to recognize Shaisha Medina. Thank you very much. I appreciate you taking the time to come on the call tonight. I'd also like to take this time to thank Reverend Talley. Thank you for joining us tonight. And I see City Councilor at Large, Councilor Christian King, who was also a member of the NAACP. Thank you very much for joining us tonight, as well as everyone else, my Carpenter brother Terrence, David Slacken, David Coyne, Judy Diamondstone, I see her on the call, Kevin Kassan, thank you all. Thank you very much, Yvonne. I appreciate you joining us. Our next speaker I'd like to bring out is Dr. Sokolov has worked tirelessly to continue to advance the progress in prevention and treatment for prostate cancer. He's a staunch advocate for fighting for the medication and again the treatment for prostate cancer. Without further ado, I'd like to introduce Dr. Michael Sokolov, who is the chair and professor of urology at the University of Massachusetts Chan Center. Thank you.
Beautiful. Thank you for inviting me to speak tonight. It's always a pleasure to share updates on prostate cancer, especially given our work here at UMass Medical School. Can everyone see my slides okay? Beautiful. So, we've already talked a little bit about how common prostate cancer is. This past year, someone was diagnosed every 2 minutes with prostate cancer in the United States, and someone died from prostate cancer every 15 minutes. Early diagnosis is key, and there are a variety of treatments, but the best treatment for an individual person depends on multiple factors, including the aggressiveness of the disease, the volume of the cancer, and the patient's needs themselves. We've talked a little bit about some risk factors in some of the earlier talks. Aging, when a man gets above 65 or 70 years of age, becomes much more prevalent. Family history, especially a brother, a father, can increase the risk 2 to 3-fold. And ethnicities we talked about, especially in African American men, have the highest rates of any American population. There's some lifestyle and environmental issues that we also like to put into the mix. But for today, let's talk a little bit about just prostate cancer in Worcester County. Worcester County is ground zero. This data is a little bit out of date, but if you look at it closely, and it really reflects what Mr. Taylor said at the beginning of his talk, about 2.5-fold increased risk for an African-American man in Worcester to be diagnosed with prostate cancer and to die from prostate cancer. It's the highest in Massachusetts in general, and considerably higher than age-matched non-African-American populations. So Dr. Stern wanted me to give a few minutes on treatments. There are a whole host of treatments for prostate cancer. It depends on the extent and the aggressiveness of disease, patient's age and underlying health, a patient's perception of cancer and treatment, and we can stratify things by both the stage and aggressiveness. And when we see someone with prostate cancer, and I saw 4 or 5 patients a day in clinic, we sort of draw the following diagram. Cancer start as localized, contained. That's not unique to prostate, breast cancer, colon cancer. They start within the organ, in this case, the prostate. Then they spread locally to the tissue around the prostate, called locally advanced disease, and then to other parts of the body, known as metastatic disease. For localized in prostate, we further define men into 3 risk categories. By risk, we mean what's the chance of over time that this will become metastatic or advanced. So when we see a patient, we first define is it localized or non-localized, and then if it is localized, is it low risk, intermediate risk, or high risk? And then treatment depends on that. For localized disease, we're talking about surgery, radiation, surveillance, where we monitor things. For metastatic or systemic disease, we're usually talking about some drug therapy, starting with androgen deprivation therapy. And I'll cover all of these very briefly in the next few minutes. The advances, and this is what Dr. Stern wanted me to talk about, is that we are really minimizing the invasiveness of our treatments and the side effects. And if we look at the different treatment options, let's start with surgery. Here you've seen some of the very dramatic differences in the last 20 years. When I trained, which was 1990s, we were doing open surgery, incisions, larger recoveries, higher side effects. In the last 20 years, it's switched to laparoscopic or laparoscopic robotic surgery, where we're using smaller incisions, instruments that give phenomenal, minimal trauma while still being able to do the same things. And then even there, in this chart I sort of showed on the left, what's known as multi-port surgery, or the most recent single port. So now, instead of multiple little incisions, we make small ones. I did surgery this morning. A patient came away with a, 1.5-inch incision and did beautifully through it. And as part of that, I'm going to show a little bit of shameless propaganda. This is us at UMass. You can actually see the date here on the Telegram and Gazette. We're on the front page back in September, where we showed off that we were the first people in New England to use that single port surgery. Smaller incisions, less invasion, less invasiveness, less side effects. And that's really where the advantages of surgery have been. How do we minimize the impact on the patient's long-term quality of life? Radiation, another excellent way of treating, whether it's showing beams from the outside or implanting things from the inside. And again, been very successful like surgery for the last 20 years, but what we've tried to do is minimize the invasiveness and the side effects. So traditionally, for example, radiation given over an 8-week period, that's what this 42 represents, is 42 treatments, Monday through Friday, so it's about 8 weeks. Now our radiation oncology colleagues at UMass are doing 21. They've cut it in half. much more convenient for people who are working, who have jobs, who have family requirements and other obligations. The amount of time receiving the treatment has lessened. And those are really the huge advantages on the surgery and radiation. It's just we're trying to make them as minimally invasive and as minimally disruptive to someone's life. Eventually, and Dr. Stern is much more positive about the applicability of this in the near future than I am, but focal therapy, using a lot of the technologies her video spoke to, where instead of treating an entire prostate, you come into our offices, we have the ability to maybe zoom a little ultrasound beam or some other type of beam right on the prostate, treat a smaller amount of the area, and again, even further minimizing side effects, the invasiveness, the impact on a patient. And this is coming. How soon? Like I said, Dr. Stern more enthusiastic than I, but this is there, and this will be there. And again, this could be, like I said, you come into the doctor's office, an hour later you're treated, and you go back to your normal daily activities, and that would be a huge coup for all of us. Lastly, advanced disease. This means cancer has spread to other parts of the body. We have what are known as first-line agents and second-line agents. First-line agents go all the way back to the 1940s, of all things. Hodges and Huggins, who got the Nobel Prize several years later, for showing the pathways of testosterone and prostate cancer. And our basic treatments are still the same. How do we manipulate the male sex hormones to repress metastatic disease? And the advances here have been, we've got lots of things on top of that. So most of these androgen ablative technologies work for 5 or 10 years, and now we have a whole host of agents that can extend that for another 5, 10 years. And those are the advancements. And really what I was hoping to do more than anything today, and I got to figure out how to get out of the screen here, is show that it's dynamic. Prostate cancer, much like the COVID talks, we're learning new things. We're learning new ways to apply technologies and establish drug treatments and other things. And the goals are, how do we best apply these? How do we best make these available? And here in Worcester, especially with the underserved populations and all of the social and political determinants of health, how do we get access to the men who are most at risk for this? And I will make a plug for Daniel Dawes. He's at the Suter Institute. Suter was, I think, the first Black Surgeon General. It's down in Atlanta. It's affiliated not with Emory, but with Morehouse University. And he has written extensively not only on the social determinants, but the political determinants of health, especially in African-American populations. And make a plug for anyone here in leadership to read some of his books, because they are incredibly insightful on how we are where we are today in terms of inequalities of healthcare. So, Mr. Taylor, I will stop at that point and turn things back to you.
All right. Thank you very much. Great job. We really appreciate that presentation. I think I forgot to mention Linda Michelle on the call. Thank you very much, Linda, and maybe David Coyne as well. At this point, we only have about 10 minutes left to our presentation. So we want to try and get 1 or 2 questions. So if our trained professionals, I don't know if Dr. Stern wants to point the questions at the professionals, but we like to try and have a short answer so we can try and take a couple of questions before we close tonight.
First, I would like to thank you so much, President Taylor. I would like to ask a couple of questions of Dr. Castile and Dr. Abraham. Dr. Castile, would you be comfortable to have members of your family, members of your community that you truly care about, to be vaccinated today, particularly children?
Would I be comfortable vaccinating?
Yeah.
Absolutely. Absolutely. My entire family is vaccinated. My kids are vaccinated. Everybody in my family, I have one. I have a first cousin and his wife who are not vaccinated, and they believe in all the conspiracy theories. So, but I've had long discussions and then I've stopped. But yes, they're all. I tell the people when I go vaccinating that it is, if I can do it, and not only that, I did it back in I want to say it was September when they were doing trials, because I was confident that the vaccine was efficient and worked, and so I was one of the trials for Pfizer. So without a doubt, I'm confident.
Thank you. Dr. Abraham, would you like to comment?
Sorry, no. And the short answer is 8 billion people around the world have already gotten vaccines. So we have robust amounts of data to support that the side effects and risks and benefits have been studied well enough. So at this point in time, the argument is not about the safety of the vaccine. I think it's unfortunately become a political toy which people have used depending on which side of the aisle one is. And others, it's just fed by unfortunate misinformation, disinformation. So that's what we are struggling to combat, and that's the ongoing challenge.
It was a very pointed question, because very frequently as physicians, we make decisions about what to recommend to everyone else based on what we are doing for our families. So thank you for your answers. Dr. Castillo, would you like to emphasize what is the take-home point you would like to make for people participating in this event and many people who will be watching this video?
I think that most importantly that I want people to get vaccinated. I am Latina, and I've worked my entire life in communities of color, and it hurts me not to see my community, the Black community, not getting vaccinated, or not understanding the fact that the vaccine is safe and effective, and that it is so important not only to take care of yourself, but also it means our entire community that we need to take care of, and those who are immunodeficient, those who are elderly, those who are young. That's who we're protecting. But overall, besides that, I think we want to stop the variants. We never say we want to go back to the lives we had. We have a lot of work to do, but I think that we do want to be able to see our friends. We do want to be able to see our families. We want our kids to go back to school and take those masks off and do everything that they were doing before. We need to get back to that. I personally, my family personally misses that. I have a new grandson who was just born that I can't go out to visit because of Omicron. And so the world would change if we talked about in the beginning that if we would get 70 to 80% of the people vaccinated, we would get that herd immunity, and that we would be able to protect everybody. And we're nowhere near that. And it'll just continue. And I mentioned that people say, well, the curve is going down for the Omicron and we're going to be done. And there's another variant of Omicron coming around the corner. And truly the only way we're going to end it is the more and more people get vaccinated. So that's my plea to the community.
Thank you so much. Dr. Abraham?
I echo that 100%. So, I have a daughter who's a school teacher, so she teaches in Connecticut, and so she's in front of a classroom of third graders, and every day we hear of kids getting sick, etc. And so we talk to her every day about the risks of potential exposure. And absolutely, the answer is, as eloquently science points out, disease only gives us limited immunity for a short-lived immunity. Vaccine is what really gives us more robust immunity. And the former Prime Minister of the UK, Tony Blair, said it best when he said, if virus is anywhere, it will be everywhere. And that's exactly what we saw with the Omicron variant. Countries in the world where vaccination rates are lowest only because of poverty and inability to afford vaccine is where the new variant developed and will continue to develop. So unless we have really carpet bombed the world with enough vaccine so that we keep rates down, that's the only way we can get this down to a flu-like situation where we can then do some sort of annual vaccination to keep people protected.
One question that was asked, Dr. Abraham, was what is the proper way of doing antigen testing? Should be done should be sampling done in the nose, or should it be done orally as well?
Excellent question. So it's interesting. In the rest of the world, oral sampling is done as well as so places do both. Places do one or the other, and the controversy came up a little bit because Omicron predominantly affects the GI tract, the stomach, intestines, etc., and not the respiratory tract, which is one of the theories behind why it's much milder than Delta and doesn't cause such severe illness with any long-term consequences, unlike Delta. And so therefore the feeling was if it's predominantly in the GI tract, then shouldn't we be sampling the mouth? But our current tests are not set up to be able to pick up enough virus in the mouth in an oral specimen. So those home kits are intended to be nasal samples. And so we should continue to use it as nasal samples, not as oral samples. But I think there are studies ongoing whether one is better than the other. There is no consensus yet. And there are parts of the world which do simultaneous testing of both, trying to pick up one or the other site. And there are some nuances to it, but I think for practical purposes, the nose still provides enough virus, with the caveat, as I pointed out, that symptoms can precede the actual virus levels rising. So a negative test when one has symptoms is not reassuring, but an opportunity to retest a day or two later to be really sure that one does not have actual infection.
Another question asked was about whether or not these presentations will be available, and I can assure everyone that our staff will edit and clean up this video, and we will make this video available to President Taylor in case anyone will be interested. Mitch, what is your take-home message to everyone who is here and who will be watching the video?
Well, first, I would echo everything that's been said by Drs. Castile and Abraham about COVID vaccination and COVID protection. And it's I find it a little embarrassing that being the richest country in the world and with all of the resources we have, we're so pathetically under-vaccinated for a lot of social and political reasons. For prostate cancer, it's kind of what Senator Chandler said when she started with her husband. It's convincing men to be aware of prostate cancer and their families, but men to be aware of prostate cancer, to talk about it with their physicians, to go see a urologist if they feel there's a need for testing, and to get tested, because it's only when we know that there's a diagnosis can we most effectively treat it. And it's, get out there and advocate for yourself and get tested. I would say those are my take-home messages.
Thank you so much. And I think we convinced you, between Dr. Sokolov and I, we convinced everyone today that right now, the major direction in prostate cancer research and clinical care is shift from invasive biopsy to non-invasive diagnostics, from non-invasive treatment from highly invasive treatment to much less invasive treatment. So the map of treatment for prostate cancer that was so scary 5-6 years ago is just no longer applies. Now we have one more question, President Taylor. Do we have time for one more question?
Yeah, one quick question. We want to wrap this up. One more.
The question is, what is being done to gain the trust of community of color who have reasons to mistrust medical community? This was asked by Jen J. Innes. Is it a question about COVID, prostate cancer, or both, Jen J?
I'd say both.
Both. Dr. Castile, do you want to address what is being done to gain the trust of communities of color in COVID?
I think I'll start by what we did in the beginning was to have, we started with town halls to educate people in the community and leaders in the community who would go back to the community to be able to talk more about it. We had smaller groups with community members to be able to, again, talk about the vaccine, talk about the importance of that. I think the other things that we have done is really and part of it has been, we started a task force through the city called COVID-19 Equity Task Force, and really to get community involved, to get the hospitals involved, and to look at how we do things. And in particular, for COVID, we're going to turn that into the Equity Task Force to look at all the other health issues that occur in communities of color disproportionately. But with that came mappings and came areas of where we needed to go to outreach into the community, so that we can't have one stationary place and say this is the place that that people are gonna come. We need to understand that people may not have access to computers, they may not have access to transportation, they may not even have the time to be able to get a vaccine. So we go to them. And we have people who speak every language, that we are able to be there, speak the language, and sort of be able to talk about, we did it, we got it, here's the reason to do it. But a lot of it is going to where people are, and that's a lot of the outreach that we've done. I can tell you, we've walked through the streets of multiple neighborhoods, multiple areas in our community. We brought medical students who speak the language. We have ambassadors who speak the language, and I certainly speak Spanish. So I think that's the piece. Could I say we got them all? No. It's not from lack of trying, but I think that overall, that's the piece that we have to do differently, is that we have to go to them. We can't continue to think that people are going to come to you. We need to change the way we do medicine, and it's not they're coming here. We have to learn to outreach into the community and really understand what the community is like. So I think that's been a lot of what we've done, and we will continue to do it. And I'm a believer that we will get to a minimum of 70%. We're at 60. You don't have much to go, but we're still going to keep going until we get there.
Thank you, Dr. Steele. Actually, the whole point of virtual events that we learned from since the start of the pandemic, it's one of the few silver linings of this pandemic, that just like bringing vaccines and vaccinations to people is important. To the same extent, it is important to bring education about prostate cancer to people, and through virtual events, we were able to reach many more time. I mean, we are talking the difference per year from a couple of thousand people to 10,000 people plus. Mitch, do you want to comment about anything that is being done in the communities of color in Worcester in prostate cancer?
Absolutely. So one, I mean, you gave mention to the equity program, which is obviously so important, and building grassroots education and access within each of the individual counties and cities. But really what Dr. Steele was saying, it's the same thing for prostate, which is you need to get the right spokesman out speaking about it, whether it's a patient survivor, whether it's members of color who happen to be urologists, which unfortunately I think less than 2% of national urologists are Black, and I think less than 1% are Hispanic. I mean, the recent census is boggling with how few minorities are in urology. But it's getting the word out to a community by role models they trust. It was funny, we started the conversation today, I think it was Senator Moore was just talking about the weekend's football games. But the American Urologic Association for years has partnered with the NFL, with some of the, I would say maybe older for an NFL player or retired players who have had prostate cancer, mostly African American, to sort of get the word out about, hey, look, this is a serious thing. Look to me as a role model, as a Black athlete, and do this. And I think that's the best way for getting the message out.
Thank you so much, Dr. Sokolov. And I would like to thank President Taylor for the same reason me just mentioned, and that is for the opportunity to bring this education through a trusted community member, such as Worcester NAACP, to the communities of color in Worcester. Thank you so much.
You're welcome. I want to say first and foremost, thank you to the panelists. I want to thank Senator Harriet Chandler. I'd like to thank Senator Michael Moore, I'd like to thank you, Dr. Fianna Stern, for co-hosting this with me with your colleagues. I'd also like to thank Dr. Castillo, Dr. George Abraham, and I'd like to thank Dr. Sokoloff. I appreciate your help. This was, you were just as, you guys are fantastic, just as good as I thought you were going to be, and actually even better. I want to thank the members who chimed in, the people who aren't members who were thinking of members that chimed in. Thank you very much for taking the time to listen to this presentation. Remember this and spread the word, right? We all have this education. Go out into the community and spread this. Thank you very much.